Activation of the cardiac cath lab for urgent treatment of patients with ST segment elevation MI is always tricky business, especially at off hours. Early activation clearly reduces door-to-balloon times. That's a good thing. But none of us likes to activate the entire cath lab team, only to find that patients do not need emergency cath or do not have coronary lesions that require treatment. The question is, how often does that scenario actually occur? Now in circulation, researchers examined cath lab activation at 14 primary angioplasty hospitals and determined the course of management, including the rate of inappropriate activation. Almost 4,000 activations were evaluated, and appropriate activations occurred in a startlingly good 85%, with 77% of appropriate activations actually receiving primary PCI. Reasons for inappropriate activations included ECG reinterpretations or the patient was not a cardiac cath lab candidate. The rate of cancellation due to reinterpretation of ECGs initially read by emergency medical techs was more common than for cancellation due to reinterpretation of emergency physicians' ECG findings. But in all fairness, the numbers were both pretty similar at only around 4 to 6%. This represents the first report of the rates of cardiac catheterization laboratory cancellation for STEMIs activated by EMTs and emergency physicians in a large group of hospitals organized within a statewide program. The high rate of coronary intervention and relatively low rate of inappropriate activation suggests that systematic cardiac cath lab activation by emergency personnel on a broad scale is feasible and amazingly accurate. I'm Peter Block, and this is a CardioSource Heart Minute.